This is Brian Wormers recording a lecture for medical surgical nursing on the topic of preoperative nursing. These are your learning objectives that are on the PowerPoint. So preoperative period, this is the time when the patient is scheduled for surgery and ends at when the patient goes into the surgical suite. At this point, the nurse functions as an educator, an advocate, a promoter of health and safety. There's lots of different reasons for surgery. It can be diagnostic to try to figure out what's going on with the patient. It can be curative to try and fix what's going on with the patient. It can be restorative, so if the patient's got a lack of function, we restore that. It can be palliative, so you're not fixing anything per se, but you're relieving some of the symptoms so the patient is more comfortable. And it can be cosmetic, so like rhinoplasties and tummy tucks and different things like that. So urgency and degree of risk of surgery. So urgency is how fast we have to get in. This is going to be elective, so it's a planned procedure. It can be urgent where it needs to be done, but it's not life-threatening now. Or it can be emergent where it's definitely life-threatening, and if you don't get it fixed, it's going to cause problems. There's degree of risk for how invasive this is. It can either be minor or major. The extent of surgery can either be simple, right on the area that you're talking about. It can be radical, taking out lots of tissue that's not obviously involved. However, you do that to try and prevent spread. So if you're thinking about tumors with metastasis, you might have a radical surgery to try and prevent it spreading out. You can have minimally invasive, and so this is usually when we're talking about endoscopy and using scopes into these spaces. So collaborative management assessment. So we're going to look at the history and physical. We're going to ask things such as the age, because the older they are and the younger they are, they've got more complications with surgery. Drugs and substance abuse can alter how they're going to react to anesthesia, if they've got any tolerance built up, or if they might even have withdrawal symptoms because they don't have that drug or alcohol on board. Medical history can play a factor depending on if they've got cardiac or respiratory issues, and that will play a major part of anesthesia's role. Current medications, how's that going to affect them? Are they on any anticoagulants? Are they on any other meds that might affect this? Are they on long-term steroids, which affects wound healing? So those will all play a role in this. How they do with previous surgical procedures or anesthesia. We'll talk about malignant hyperthermia here in a little bit on the next PowerPoint presentation, but that is a major consideration for surgery. Blood donations. What type of blood do they have? What type of blood will they receive? Do they get autologous blood, which is blood that they previously donated and now they're collecting it back? Or is it from a family member, or is it from somebody completely different? Discharge planning. So we've got to start this from the beginning, and what kind of home environments are they going into? What can they care for themselves, and do they have good support? So physical assessment, always get baseline vital signs, and this is really important, not just for pre-op, but inter-op and post-op. We'll also look at these to see where this patient's at and how far from normal they are. Do need to focus on those problem areas, but know that all systems can be affected by surgery. If you see anything out of whack or abnormal, please notify the providers so that they're aware of it. System-wise, we talked about cardiac and respiratory being huge. So have they had an MI? Have they had coronary artery disease, hypertension, dysrhythmias? For respiratory, any chronic respiratory problems, so COPD, asthma, obstructive sleep apnea. Smoking will cause problems, and it decreases oxygen delivery. And renal and urinary, we want to make sure that we don't have any drugs on board that's going to cause renal problems and failure. Neurological, so we want to determine the baseline, because if somebody is disoriented from the get-go and PACU isn't aware of that, they might be trying to hold on to that patient until they get to a normal finding, and that might not ever happen. Musculoskeletal, any obvious deformities or breaks. Nutritional status, patients that are malnourished or that are obese tend to have increased surgical risks. You want to make sure that they've got enough protein on board to help heal and enough calories to recover, but too much can also be a detriment. Psychosocial, how is this affecting the patient? How are they dealing with this? How are they coping? And what support do they have? Labs, so UA, you can do a blood type and cross match. You might see a CBC or hemoglobin level, trying to get a baseline for that. Clotting studies, of course, for PT, PTT, INR, and maybe even an anti-XA, depending on what kind of meds this patient's on. But you want to make sure that this patient's going to actually stop bleeding after you cut into them. Electrolyte levels, you don't want to have any seizures on the table, and so we monitor those. We don't want any heart arrhythmias either. Serum creatinine, looking at kidney function. Pregnancy test is major. We do that on most patients, even if they say that, they're a virgin or they've never had sex, because guess what? Sometimes they've been surprised too. Chest x-ray can be done to look for any pneumonias. EKGs can be done to look for any arrhythmias and make sure that that doesn't happen on the operating room table. So informed consent, so the surgeon or whoever's doing the procedure needs to get the consent, and they're the ones telling them about what's going on. The nurse's responsibility is saying that the patient signed it of their own free will. It is not the nurse's responsibility to talk about the pros and the cons and the risk factors and all that stuff. Patients can sign with an X. It seems a little outdated, but if somebody can't spell their name or sign their name, an X is legally binding. In an emergency, a telephone authorization is often it is acceptable and it's often preferred. However, if it's life or limb, we don't need actually any. If it's life or limb. Dietary restrictions, so nothing to eat. Generally speaking, for adults, it's by midnight the night before. For kids, we'll do everything from 2 to 6 hours, and we'll cover that more in pediatrics. Time frame is very controversial. We're lacking some evidence for this, but those are kind of typical things for where I've seen in my practice. If they eat before, they're at risk for aspiration, and given that risk, oftentimes the surgery will be canceled if it is a non-emergent surgery. Giving regularly scheduled medications is huge. Talk to the providers as to which ones they want. Generally speaking, the things that they don't want to have happen on their operating room table would include any cardiac or respiratory things. So cardiac disease, arrhythmias are a big thing. Respiratory things such as asthma or COPD, seizures, or hypertension. So all those can be complications related to a surgery, and so it's better for them to take their meds. Anxiety interventions. So giving them all the factual information prior to a procedure can often help with this, and letting them talk through any concerns that they might have. Try to promote rest as much as possible, and then use some distraction, whatever is relaxing for them. We can also teach family members at the bedside, and that does help with retention of information because it's two people learning the material. Patient preparation before surgery includes removing most of the clothing, providing a gown. They really should leave their valuables at home or with family, but if not, then they can lock it up. Try to tape rings in place if they can't be removed, and then also always make sure your patient's wearing an ID band. In pre-op, it's not as important, but when they're unconscious in surgery and in PACU, it's immensely important. Things to remove, such as valuables, any jewelry, including wedding rings, dentures, prosthetic devices, hearing aids, contact lenses, nail polish, so you can get an adequate SAT, and any artificial nails, as it can harbor some bacteria. Prior to having surgery, they should also sign the surgical site, especially if it's bilateral, to make sure that we are doing surgery on the correct thing. We can ask about different body modifications, such as any of these piercings, and we're concerned about that because of the risk for having it causing a burn injury with electrocautery. Skin prep, this is going to vary depending on what area you're operating on. The provider will tell you what area they want prepped. We used to shave, but we found out that causes microcuts in and dermal abrasions. So we no longer do that. We do remove hair by clippers if needed, and then they can shower the night before using antiseptic solutions. And often in the operating room, of course, they will be prepped. And here's some of the preps that they'll do in the intra-op, depending on what surgery they need. Medication before surgery can often include anti-anxiolytics, sedatives, things to reduce nasal and oral secretions, such as anticholinergics, things to produce or to prevent vagal-induced bradycardia, H2 antihistamine blockers, and then some opioids. The interesting finding with some of this stuff is if you give anti-nausea meds, anti-anxiety, and anti-pain meds prior to the start of surgery, throughout the course of surgery, they generally speaking will need less because you get on top of that and then you follow it up appropriately. Prevention of complications can include breathing exercises, such as incentive spirometry, coughing, and splinting. Patients are at greater risk for DVTs, so that's why we've got to make sure that we're being proactive with these patients. Patients that are obese, older than 40, have a history of cancer, have immobility, spinal cord injury, history of clots, birth control pills, smoking, a decreased cardiac output, or having total joint replacement surgery are at an even increased risk for DVTs. We try to prevent that using anti-embolism stockings. That's a common finding. Some of the new research is saying that it doesn't help that much, so it's an interesting consideration. We can also use pneumo boots or pneumatic compression devices. We can do leg exercises, getting them moving, and the mobility, which is paramount. Patients that are at risk for venothrombosis would be obese, over 40, all those major things that we just talked about. So here are some of those pneumo boots and compression devices. Chart review is important because we need to know what's going on with that patient. We need to make sure that all labs are done, all diagnostic tests are done, and that they're in the chart and available for all team members. We want to make sure that we document that things are done, procedures are done, orders are complete, and we want to make sure that the patient is ready to go for intra-op. National patient safety goals and informed consent. So we got to make sure that the consent is signed, but we also have to look at national patient safety goals and make sure that we are protecting our patients, especially when they're so vulnerable, when they're unconscious. Informed consent, we talked about that before. So risk factors related to aging. So they have a decreased cardiac output and peripheral circulation. They have decreased vital capacity. They've got some blood flow to the kidneys, but it might be diminished. They might have an increased blood pressure, increased risk for skin damage and infection, sensory deficits, and then, of course, osteoporosis or arthritis can cause complications, especially when you're positioning them for surgery. Other considerations would be, do they have any allergies to anything, any chronic illnesses that are going along with this, malnutrition, are they getting enough proteins and calories, do they have an impaired self-care ability, do they have supports, how are they going to tolerate the stress of surgery and anesthesia, do they have a strong enough cardiopulmonary background that will support them while they have surgery, any mental status changes, or any risk for falls. This concludes this presentation. If you have any questions on this, please contact your instructor.